Welcome to the April Valleywise Grand Rounds. This morning, we are very excited to welcome Dr. Tran to speak with us about social media content creation and its role in medicine. Now, Dr. Tran received his medical degree from the University of Colorado, then did his pediatrics residency at UT Southwestern, then pediatrics GI fellowship at Children's Hospital of Colorado. All of that before coming here to Phoenix and joining Phoenix Children's Hospital's GI team. Now, Dr. Tran is very passionate about education and is also active on TikTok and Instagram, creating content for healthcare learners. As with every month, please make sure to have yourself on mute unless you're asking a question, and we'll also be putting the CME link in the chat starting about midway through. With that, I will hand the floor over to Dr. Tran.
Perfect. And Dr. Tran will be back in just a minute.
All right, thank you so much, Dr. Maurice. I didn't know about the TikTok ban or the outcome of it when I made this talk. So it's entitled From Reels to Real Learning, Growing as an Educator by Creating Content. You can also substitute from TikTok to teaching, growing as an educator by creating content. So this time last year, made a match day video about my match process. We just had match, a lot of emotions around that. And I shared my match story of having expectations of going to one of my first two choices because I thought I was a rock star, soon to be pediatric intern. Didn't think about anything below my second two choices. Opened my envelope to see my fourth choice, was completely devastated, not because I got my fourth choice, but because it wasn't going to be my first two choices. And I hadn't even thought about that reality. Looked across the table to see my sister who had matched her first choice in neurology at our home institution in our home state. Her face fell as she saw me essentially starting to break down in front of her. And she just very quietly told her husband that she matched her first choice. I ran out of the room, essentially found a corner, and I just started cuss crying, if that's a term. I shared that story really to encourage people going through the match process because I know exactly how difficult it was. I think overwhelmingly the response was positive. People reaching out, I've talked to probably close to 100 students, now interns, who reached out and said, your story meant a lot, or people who just matched and said, your story last year encouraged me, and I reposted the same thing. But the problem was not the overwhelming encouragement. It was a very small but loud minority who told me that I was an entitled brat for being completely devastated for matching at my fourth choice. Boo-hoo, you selfish bleep, for even matching in the first place and complaining. For matching your fourth choice, some people work for years to match into a field period. I would never go to a physician like you. I said, wow, this was meant as encouragement.
All good. The only thing,
at the end of the day, for me, if I didn't have a reason for doing what I do on social media and creating content, that would have devastated me. That would have rocked me to my core. I would have quit. I would have said, why do I do this? But at the end of the day, I have a very real mission For every single person who watches my videos, I want them to be encouraged, inspired, equipped for success. Really, I want them to be a medical trainee, a medical student, a resident, a fellow, maybe a junior faculty member watching this and saying, wow, I think I can make a difference, or I think someone sees my experience. I am a consultant, finally, for an endoscopy company, but this content has nothing to do with it as my role as a consultant, and I've not been compensated for this presentation. I've been waiting for something to disclose.
Good morning. I guess most of us are online today.
Thank you to the 15 or so people in the room. Really appreciate you. This is not an empty hall in front of me, but thank you for those of you joining online. My learning objectives for this presentation are simple. I want everyone to understand why educational best practices are important to both educators and clinicians. Why am I here? I don't care about social media. Why am I here? I don't care about education. Well, it's important to you regardless. Discuss 3 elements of effective education, and I want to explore practical ways for busy clinicians like many of you to improve patient and learner education. At the end of the day, I hope that you come away with one single tool, if not more, to improve your own practice. Why does it matter? It's very simple. We're all educators. We're in a field where we have to educate learners. We have to educate parents. We have to educate and empower patients. If you tell a patient to do something, a 3-year-old is not going to do it. I can tell you from very personal experience. But if you tell their parent, and their parent happens to be a pediatric subspecialist, they probably still won't be able to do it, but they'll be better equipped to do it. We are all educators. It's very important for us to be able to communicate well and tell our patients exactly what we're thinking. They actually looked at the competencies, the ACGME looked at the competencies of an effective clinician. They looked at core competencies of actually a clinician educator. Medical knowledge, professionalism, learner-centeredness, practice-based reflection, communication skills, and systems-based practice. That is the exact same list of competencies of residents, of pediatricians in training. They just changed learner-centeredness to patient-centeredness. That's it. The same competencies exist if you're a learner, a pediatrician, a physician, or an educator. This is why it's important. You can still use these tools broadly. And I would challenge you and say that anytime you have staff, if you are not a complete solo practicing physician, someone is learning from you.
Our medical student gets to choose music today. What would you like to listen to?
Wait, are you sure?
Yeah.
How about Creed?
How about no?
We've all been in the operating room if you've gone through medical school where music becomes a theme of the day. I hope, unlike this OR nurse, we embrace Creed today. Because Creed underlies the elements of effective education, as I've learned from social media. And no, it's not a post-grunge rock band from Tallahassee that's had some incredible hits like Arms Wide Open. Creed is what I've come up with as a nice tool. 3 elements. Education needs to be credible and relatable. It needs to be effective and efficient, and it needs to be dialogical, involve a dialogue. These things I've learned from social media. I want to break that down, give you practical tips for education. Why did I start a social media? People who don't know me may think that I create content as a TikToker, where I have over 140,000 followers. Or maybe they know me from Reels, Instagram Reels, where I have over 140,000 followers. So From my social media content, my platforms, I have almost 300,000 followers. That means nothing. Again, if my audience just follows me because. I think I have a very clear mission that I've had from day one. I've been creating content since I was a third-year fellow. And I did it because I saw a giant gap. Everyone on social media, it seemed when I was a fellow 3 years ago, was creating content to really show how you study in the first 2 years of medical school. And residents were using it really to talk about their resident experience. And really, that was it. There was nothing about navigation. There was nothing about culture. There was nothing about how do you actually succeed. And the medical educators who could do something were on med ed Twitter, where there were no learners. I'm like, why are you not talking to the learners? Why are you not in front of your audience? So I said, I want to be in front of the audience. Where are students? Where are learners? Where are the trainees that I want to talk to? They're actually on TikTok and Instagram. So I went to those platforms. I started making content on how to give better feedback, how to get better feedback, how to get better precepting, how to present better, how to navigate the clinical system. And I honestly felt really good about it. 6 months in, I made a post about changing the culture of medical education. And a follower said, hey, no hate. I love your content. It's really helped me. But how are you changing the culture of medical education? Seems like you're just giving us tips to navigate a present culture. And I said, dang, truth hurts. That is really raw and true. And I thought about that and I completely changed the way that I approach my videos. And from that moment on, I became a meme lord. I made memes and then I became more of an entertainer with skits. And I realized that I had to change the way that I conveyed my message. I had to calibrate to what my audience was wanting, what my audience needed. And let's face it, for those of you who have been on TikTok or Instagram once, you're not going to TikTok or Instagram because you're yearning to learn. You're not going there because you're like, you know what? I'm going to sit down and prime myself for a day of studying by looking at a TikTok video. No, you're sitting on a toilet. You are standing in line at Starbucks. You have a lunch break, 5 minutes downtime. You're waiting for an admission and you're like, I've got no one else around me, so I'm going to doom scroll. People want quick hits of dopamine. They don't want sustained education. That's not the platform for it. So you have to calibrate to the level of your audience, the level of the needs of your audience. And I pride myself on relatability, which I'll break down. The first part of Creed is calibrated and relatable.
Security was getting a little suspicious because I kept trying at the door.
If you've never seen my content before, that's kind of it right there. I summarize the medical student experience that is near universal. And this is very relatable. All of us have had the experience or know of someone who's had the experience of having a badge that doesn't work, showing up on the first day, having to sneak through a door because you're scrambling to get in through an open door when no one else can let you in. Security is getting suspicious at you. You get locked in a stairwell. You're wandering around aimlessly because no one knows you're coming. Your preceptor's actually on vacation on your first day. I love it when people message me. One of the best things that I can get is a message that says, how did you get a video of me? How do you know my experience? Wow, I've never had a unique experience in my life. This is so relatable. That's my secret sauce, relatability and an authentic connection. Because people watch what I make and it evokes emotion or experience of their own. They're not identifying with my experience. I'm identifying with their experience. So what does this have to do with education? Well, there's something called the expert blind spot in medical education and in education overall. It's where educators, it's where people who have a lot of experience cannot for the life of them, tailor their experience or their teaching to the level of a novice learner. This is called, in another word, unconscious competence. In the experiential mode of learning, you start kind of where we all do, what's called unconscious incompetence. You don't know what you don't know. And then over time, you get consciously incompetent. You know what you don't know. And then over time, we all kind of land at unconsciously incompetent. Or sorry, unconsciously competent, especially proceduralists. I'm a GI doc. I do endoscopy. Over time, I learn muscle memory. It's very difficult for me unconsciously to translate that into conscious direction. Hey, you need to move like this. Move like this is not helpful. You need to angle your wrists in a certain way to torque 45 degrees so that you can change the tip of your scope by whatever, going to 9 o'clock. That makes a lot more sense. It's very difficult to translate that, especially for procedural tasks. But you can see the pediatrician who recognizes roseola on day 3 before the rash. Very difficult. How do you translate your experience into practical knowledge? It's very hard when you're an expert.
I was unable to palpate an olive mass in the epigastrium. In initial imaging, there was no double bubble or triple bubble. Kidney ultrasound showed mildly heterogeneous renal parenchyma suggestive of medical renal disease correlate clinically. They were originally concerned overnight about interception. Wow, I can't read my handwriting. Intussusception. But mom described bloody mucousy stools. She didn't say anything about currant jelly.
So when you see this whimsical take on medical student sign out, which that may or may not have been based on a true story, sometimes you have a mismatch of information delivery and information necessity. Sometimes you're getting too much information there where you don't need it. And guess what? The opposite is true. Sometimes you are getting too much information as a learner that you are unable, unwilling, or unprepared to accept. It's very difficult when you have a mismatch of expert and novice. We've all seen this. Again, as a gastroenterologist who is primarily inpatient, I don't do clinic. I'm on the inpatient service primarily. We have discussions all the time. I overhear or maybe even take part in discussions all the time of risankizumab. Should we do induction of risankizumab or should we do BID dosing of upadacitinib? Maybe TID dosing of upadacitinib. Maybe we should do tofacitinib because there's a liquid formulation, but then prior authorizations require that we do a first-line therapy like an anti-TNF. This is flying over everyone's head when you are a learner, or maybe you're everyone else on the team, just trying to figure out if the kid has ulcerative colitis or Crohn's. I'm still trying to catch up if this kid has defined IBD. And you're talking about different dosings of second or third or fourth tier medications. I cannot keep up. Like that, the audience is mixed. Social media has taught me that. I have to create content that goes to my followers. Yes, I have a modest platform, but I've built a really good community of people who come back for my content. I have to create content that appeals to them. They're following me for a reason. Yet I also, if I want to grow, have to create content that is generalizable to people who don't know what I do, don't know what I'm talking about, but are intrigued to learn more. So there's the dilemma right there. How do you calibrate? How do I want to grow and yet at the same time appeal to my platform? The medical education literature shows us this. The difficulty of mixed learner levels. Timing, it's very busy on inpatient services. Complexity of the service. You're thinking about a lot of different things. You're managing different levels, not just patient care wise, but also education. How do I teach the day 1 third-year medical student at the same time empower a third-year fellow who is going to be my partner in 2 months? How do I calibrate that? I promise tactics. Here are 3 tactics for you. Number 1, know your audience. On social media, I had to define my niche. People talk a lot on social media about the algorithm. If you've thought about creating content at all, you've thought to yourself, my content is not good, or the algorithm hates me. I'm just not growing. Well, substitute algorithm with the word audience. Your audience doesn't hate you. It's just not tailored. Your content isn't tailored to your audience. So I had to think about my niche. Who is watching my video? What do they want? Entertainment, education, emotions, community? That's what I have to think about. The value that I give with every piece of content that I create. It is very intentional. And online, I have the luxury of time. I'm talking about a 3-year window where I've grown my platform. How does this apply to education when you have a half-day of clinic with a learner? I don't have time for them to show up day after day after day with the next piece of content, hoping that it catches. I have to meet them where they are. I don't have time. So sometimes to know what your audience wants, you have to ask them. Number 1, for teaching, to be able to calibrate, ask your learner what they want. What value can you provide? It's so simple, yet we don't generally do it. What are you working on is a great place to start. The advanced novice is another. You don't have to rely on calibrating if you're a brand new attending or you're decades into your career. You don't have to worry about, well, for the first time, I have a medical student and a resident. How do I teach both? Residents a lot closer to the medical student than you are. And equip and empower the resident to teach the medical student. Fill in the gaps that way. You are empowering someone else. And the last thing, this is my favorite practical tip. The residents who have worked with me usually hear me say this on round, situational awareness. I picked this up in the ICU as a 2nd-year resident, never looked back. Situational awareness is simply, I ask interns and residents, if you are alone at night and no one else is picking up the phone, you cannot touch base with your fellow, your attending is busy, no one else is around. What do you do if you get this page? What do you do if a patient calls out and says this, steps into the hallway and a mom says, I need help? What do you do in these emergent situations? How do you respond? Not just what is going on, but how do you respond? How do you respond to what you respond with? The labs, the tests, the exams that you order or perform? How do you use that information? And I try to teach this so that people can then rise above the level where they are. So medical students can practice this. You only get a couple of patients assigned to you. You can actually say, you know what, I have a list of 10. For the patients who are not my own, I'm going to mentally go through and say, this patient who has malnutrition coming in with electrolyte abnormalities, what do I need to think about if they have a seizure? Oh, maybe hypoglycemia, maybe hypocalcemia, maybe hyponatremia from dehydration, could be electrolytes, could be, came in with a fever, maybe it's a neurologic infection. So you can go through and have that mental preparedness for the time where you need it. The second part of CREED that I've learned is be efficient and effective.
So these are all my learning objectives. As you can see, we have a lot of things to cover today, so you can review these on your own time. I actually don't know what this is supposed to be showing you. These aren't my slides. This won't be on the slides that you have. I added this morning. So you can see here that I tried to simplify it a little bit for you, more of an FYI slide.
We've all been in that lecture where you're like, dude, you're only 2 learning objectives in, and it's been 50 minutes, and we have 7 more to go. That presentation is neither efficient nor effective, and when it is efficient, it definitely is at the expense of effectiveness. Likewise, residents have all been in the team room at 2 p.m. when you're being inundated with things to do. You get nurse pages for a patient who is not doing well. You have discharges to get out the door. You have new admissions that are coming in. You have orders to put in. You have consultants who haven't called you back who are now calling. You're calling outside hospitals for records for the patient that you just admitted. And in all of that, someone says, I have a timed lecture for you at 2 p.m. The attention does not match the intention. Their attention is not there. The intention is golden. That is a great time to go back to the first part of Creed, which is calibrating, reading the room. Most people do this very, very well. Come in, wow, there are no residents here. There are no learners here. They're all gone. I'll come back. But it shows that need for timing and also efficiency. Medical education literature, as cognitive load increases, attention then decreases. This makes a lot of sense. The more that you think about, the more you're stretched thin and your attention is very, very divided. I'll just say from a personal note, as a guy, I say this to my wife a lot. I'm sorry, but I cannot multitask. I'm literally 5 steps behind you. I'm still trying to do step 1. It's very hard to multitask, even though we all get really efficient at it in medicine. And you know what? On social media, you know what the biggest thing as a content creator that I've learned is? I am fighting a thumb war. That is my enemy. My enemy is not propaganda, misinformation. My enemy as a creator is the thumbs in every single person who's viewing my content, because you scroll with your thumbs. Unless like you're on an iPad and sometimes you scroll with your finger like this, but most people scroll with their thumbs. I'm fighting a thumb war as a creator. Let me give you some insight. TikTok, Instagram, YouTube Shorts, all these short form platforms, they have a metric of less than 3-second views. Monetization, which is the act of getting paid for views so that platforms can have advertisers, they actually have a metric that disqualifies a view under 5 seconds. TikTok will not pay if someone watches your video for less than 5 seconds. That view just doesn't count towards your count of monetization. So these platforms are very, very tuned towards getting people hooked. And you can talk all about addiction and you can talk about dopamine, but at the end of the day, that's what marketing tactics come down to, the hook. Less than 3 to 5 seconds. Can I hook you with information? YouTube has something called click-through rate. The thumbnail, the title, is it catchy enough for you to click? Doesn't matter how good your information is. It doesn't matter how good of a lecturer you are, how amazingly you break down crash and burn of Kawasaki disease. If people are falling asleep or zoning out, the second you start talking, your information, no matter how good it is ineffective. You need a hook.
What do you remember about the 5 congenital heart lesions?
There's a hand thing. It's a truncus arteriosus, transposition of great vessels, tricuspid atresia, tetralogy of Fallot, and then total anomalous pulmonary venous return.
Wow, nicely done.
I started that video with a hook. Someone off screen, an attending, asking, what do you know about cyanotic congenital heart lesions? That should immediately evoke certain things. In some people, it's curiosity. Oh, I don't remember what the cyanotic congenital heart lesions are. I should tune in. That question took 2.5 to 3 seconds. Or, oh, I'm not on social media to learn. This is emotionally dysregulating. But now I'm intrigued. I'm going to watch past the first 3 seconds. Or I don't like what it's like to be asked and not know something. Regardless of the hook, the learning of the hands or the finger gestures for the 5 congenital heart lesions is very catchy. It's very sticky. So much so that I learned that on my first rotation of intern year. I started on cardiology at Children's Health in Dallas. I have never forgotten it. And here's the thing. I have taught so many people that, and so many people have learned it from other people. Why? Because when you do it, it makes such perfect sense. And it's really quick and it's easy to show people. So I then share it with someone else. Oh, interesting. I like it so much. I got so much value from it that I shared it with someone else. That is the essence of social media and virality. You don't want to create content. I don't want to create content where one single viewer says, wow, I liked this, and then moves on. I want to create content that's so good, I have to share it with my friends. Someone else is going to get value out of this. When you go to a restaurant that you love, you want to share it with the people who you care about. Hey, you should check out this restaurant. It was so good. The experience was so good. The food was so good. That's the same thing with content, and it should be the same thing with catchy things that you learn. We can be natural educators this way. Now, when we talk about efficiency, there are models out there that most people recognize. This is from The Curbsiders, a fantastic podcast. The 1-minute preceptor has been espoused in medical education for a while. This is a teacher or educator-centered model. And then the SNAPS model is more of a learner-centered model, which requires for advanced learners more motivation. But these are ways that you can use frameworks to teach in really 1 to 3 minutes. So educators who are thinking, I'm sorry, but I have a busy schedule today. I have 30 patients. I can't possibly stop. Well, some of these models are meant for exactly that. Busy clinic preceptors. Intentional preceptorship does not have to take a lot of time. In creating content now, I use AI really to speed up my efficiency. This is open evidence right here. I put in a simple prompt, and it's all about prompt responsiveness and prompt etiquette when you are using AI platforms. I'm a new pediatric hospitalist teaching a team of pediatric residents and medical students. I'm giving context for the first time. What are 3 high-yield teaching pearls that I can give to the team today, primarily based on bronchiolitis, since we have so many patients admitted with it? Now, I'm not going to insult my audience's intelligence. Most of us are well-versed with bronchiolitis and things that we can ask for it, but this is an example of a prompt. You give context, and the thing about open evidence, which is different from ChatGPT, if you're not aware of it, is it actually looks at PubMed data. It looks at the abstracts from PubMed and other credible sources, and then links it right to those sources. So this is actually right from open evidence. It's now in the browser itself. This is from the New England Journal of Medicine. So it's a beautifully synthesized table actually from the New England Journal article that they put into the open evidence answer. So now what I can do is I can show learners the very high yield sources that I would go to. I want you to read the same high impact, high yield journals that I do. Pediatrics, New England Journal, JAMA. Go to credible sources and then read those sources. Don't rely on the AI to tell you. So how do we use this tactically? Number 1, make it memorable. Just like my match day story, emotions are really memorable. So I could tell you all about portal hypertension. Let's talk a little bit about blood pressure in the portal vein, and let's talk a little bit about, like, do we do wedge pressures, and let's talk about ultrasounds and Doppler. Or I could tell you about the time that I went in feeling really confident about an upper GI bleed, thinking it was an ulcer in a teenage patient. The ED said, yeah, just hemoglobin dropped, no major history. Go in, and he starts bleeding in front of me, starts throwing up blood in the endoscopy suite to the point where I am shaking. I'm like, I have never seen a bleed like this. I've never been unprepared for a bleed. This is where I'm really well-versed and well-prepared. Oh, geez, this kid has esophageal varices. This kid doesn't have an ulcer. Well, for you non-gastroenterologists out there, variceal bleeds and non-variceal bleeds are extremely different. Very, very hard to take care of variceal bleeds, especially that with that volume of bleeding. So I could give you that story, evoke that emotion of panic, of fear, of even an endoscopist to say, yeah, and it's really important. In hindsight, I should have asked about the spleen exam. I should have asked about sequelae of portal hypertension before. So teaching Pearl, think about signs of portal hypertension for anyone who comes in with a GI bleed. Really important to document splenomegaly or assess for splenomegaly. I could give you that Pearl, or I could give you a story that accompanies and belies why it's so important. Effective and efficient clinic preceptorship. I'm going to share my personal strategy. I'm not in clinic anymore, but when I was, I would have learners for, let's say, a half day of clinic with me. If we saw multiple patients, the standard model of clinic preceptorship is you go see the patient, come back, present, we'll go in the room together, you document. My model gives feedback in the process. It removes cognitive load. Number one, the first patient, always you shadow. Don't bring in your computer. Don't write a single thing. I don't want you to take notes. I just want you to watch me talk. Watch my bedside manner. Watch the way that I communicate. Look at the questions that I ask. Listen to the questions I ask. Look at how the patient responds to my education. Just take it in without any cognitive load. Number two, then the second patient, and this doesn't have to be 3 sequential patients. This can be graded or extended and graduated throughout the entire clinic day. But the second step is then let's go in together. I don't want you to write a single note. Why do I need you to write a note? It's cognitive load for you. You go in, you interview the patient, you talk to the family. I'll watch you. And guess what? I'll scribe. I'll write my own note. I'll take down notes while you do that. It's efficient. I'm not sitting outside waiting and doing other things. I'm taking care of the patient. I'm listening to the exact same thing the learner is. And then I might ask the parents to excuse us as we step out. And I have a learner, whether a medical student or a resident, give me an assessment. Hey, what do you think based on what you heard? What plan would you like? Still gives you the chance to flex your muscles as a learner. It's a safe environment outside. And if you get comfortable, we could do it in the room too. And guess what? No cognitive load from writing a note. And we heard the exact same thing. So I don't need to question the information that you're presenting. I heard the exact same thing. If I have vital information that I need, I might ask that in the room. But then we go in and present to the family. And then I might have you, if you're comfortable, present to the family and start practicing that way. But I can give you feedback on the questions you ask, the conversations you have, your own bedside manner and your communication. And then third, we can move to the standard model where you can see patients. But this way, it allows you to get feedback in the areas that you want. So learners can have intentional preceptorship, and it's effective if you actually combine these elements and it doesn't disrupt clinic flow. And AI for effectiveness, not exchange. For me, again, as a content creator, if I use AI exclusively, I would not have a platform. The algorithms would essentially suppress AI-generated content. I would lose my voice, my authentic connection, my emotion, if I use AI exclusively. AI makes my process a lot more effective, though. Similarly, you can do that as an educator. You can't replace your own clinical reasoning with AI. AI can help you get to the sources that refines your clinical reasoning. Lastly, last part of CREED, dialogical. When I made my match day video last year, I wanted to stimulate conversations. I wanted to evoke the emotions that I felt. I wanted people to realize they were not alone in this process. It was so bad for me, and I wanted to uplift others. And I shared my match day story. But I wanted to further that conversation. What do you do? And tell me about the match.
I'm a pediatric surgeon. Match was a long time ago. I got my third choice, and I thank God I didn't match my first choice.
I'm a pediatric anesthesiologist. I didn't actually match the first time when I applied for general surgery. Scrambled into my prelim spot. Was pretty bummed out, but after a little soul searching, reapplied for anesthesia, got my 10th choice, and now I'm happy at my first choice for my job.
You can be really successful and have a giant setback or a perceived setback, like matching at your third choice, your fourth choice, not matching at all, scrambling or soaping into a different field, and then going into your desired field, or switching careers. I wanted to start a positive dialogue about how people find success. And that video clearly struck the best nerve, because between last year and this year, across platforms, that video has been seen almost 10 million times. What does the literature show us? You can promote competence by believing in, challenging, and then imparting the belief on learners. I'm manifesting your success by believing in you, telling you that you will be successful, helping you achieve that success, and then you have that belief internalized. Competency, not usually the definition of competence that we think about. So on social media, one of the things that I want to do is, my tagline actually is to promote and encourage, equip, and empower medical learners. This is my broadcast community on my Instagram, where I share notes and messages. And I wrote here, in my training, I met a physician who was beloved by his patients, his peers, his staff, his trainees. He put people first, and it showed. He inspired me to pursue a career measured primarily by the impact I have on people, not the awards I win, not the publications I list, not by the titles I carry, not by the positions I hold, by the people I impact. So in that vein, again, my mission is very clear. I then engage my community, ask the learners, hey, after I made a skit of a kind attending and a kind senior resident, what are ways that attendings have been kind to you? Initiate table talks for med students, found me pre-rounding, show me a cool physical exam finding, made breakfast for everyone, brought it to table rounds. I mean, that's exemplary. Talked to me about their field, gave me time to ask questions. It matters. Said, I'm so proud of you. Said, I'm proud of you. Gave me access to the physician's lounge to get free food. Food is very important. Very, very. Inviting me to lunch multiple times and treating me to lunch all the time. Very, very, very important. Drew pictures. Intentional preceptorship. But at the end of the day, it's positivity. But guess what? In the literature, there's something called the positivity principle, where just by being positive, educators can improve learning, improve long-term retention, can actually improve that objectively on testing, and can create that community around them. They become more credible just by being positive. That's it. So the last two tactics that I have, wise feedback. I gave a grand rounds on feedback last year, and wise feedback was one of these amazing principles that I learned from a hero of mine, Adam Grant, who's an organizational psychologist. And it was very simple. Instead of saying, here's feedback for you, or I have feedback for you, you say, I'm giving you this feedback because I have high expectations, but I'm confident that you will meet them. This is not giving learners a free pass. This is not giving people around you a free pass and being nice. This is holding people to a high standard, having high expectations, but then expressing confidence that they'll meet them. Why? Because you are helping them meet them. I can see this sitting in a patient room. You empower patients and parents. I know that this is very hard to take in. This is a new diagnosis. It's very difficult. But it's very important that you do this, because you care for your child and you want what's best for your child. We have the same goal, and express goal, expectation. But I'm confident that you will be well equipped. Now let me equip you. you can use this in the clinical world too. And prompt reflection, just like I engage my community. I said, hey, what are ways that attendings have been kind to you? Prompt reflection. As educators, we are just coaches. That's all we are. I talked about having something stuck in your teeth, and feedback is, hey, you got something stuck in your teeth. Coaching is merely saying, you've got a blind spot. There's something that you don't know. It is not picking the kale out of someone's teeth. That's just gross. If you have something stuck in your teeth over and over and over again, I'm going to tell you until you realize for yourself what the feeling of something stuck in your teeth feels like. And then you take care of it yourself. So we're prompting reflection. In the clinical world, we can prompt our patients and families to reflection. What do you think about that? How do you feel like you're doing?
We made it to the end. Again, these are not my slides, so those are not my kids, but this looks like an awesome vacation.
Thank you.
All right, we can open up the floor if there's any questions. I don't see any questions yet in the chat. Just as a reminder for everyone, the second Tuesday of the month is Valleywise Grand Rounds, which is why it's a different Zoom link. And so when entering the code, it needs to be on the online Creighton website or texted to the Creighton phone number if you have already set that up. And if you're texting, you type attend and then the code. With those steps, this code is working. That addresses the majority of the comments in the chat. If there's anything else, I'll keep an eye on that.
There's a question in the room here. Yeah, thank you for that question. The question is bite-sized learning, and the approach to bite-sized learning now on social media and education has definite benefits, but may sometimes lack depth or foundational principles. So how do you reconcile the two? I think it's very important because I talk about it all the time when we're studying. A lot of medical students study pure vocab based on Anki cards or space-based repetition cards. Well, you can't speak Spanish if all you've done for a year, or you can't go to Mexico and carry on a conversation if all you've done for a year is Spanish vocab words. It just doesn't work. So you need vocab to build a foundation, but then you need to be able to apply. So there's a difference between knowledge acquisition, which may be bite-sized, and then knowledge application. So what I would say is deliver the bite-sized education and then really promote and encourage a learner to apply it in a clinical way. So for instance, if I give a bite-sized, very bite-sized pearl on that's specific on the recognition of ulcerative colitis requiring certain lab work, not only symptoms, but platelets, but so high platelets, low albumin, microcytic anemia. These things could prompt my recognition of a chronic inflammatory process and maybe inflammatory bowel disease in the right scenario. Great. Now apply it. So if a patient were to come in with bloody stools and some of those things, but not all, what other things should you be thinking about? What other things can guide you towards a diagnosis regardless of that? So it's stepping a little bit outside, adjacent to that bite-sized pearl and saying, well, apply it in a similarly related, a tangentially related, or maybe a completely distinctly different. So I like to do that on the wards where I say, hey, what if you have that same patient, except instead of 6 weeks, you have 6 days of bloody stool, and they're coming in now with swelling, They're coming in now with abdominal pain, but they're also coming in with low platelets. What do you think about that? And I try to guide a learner towards a diagnosis of HUS rather than a diagnosis of IBD, because the platelets are the discerning feature. But if you're just focused on platelets, and then I think you kind of lose the fact that, wait, why do you have edema? Why do you like this is a distinctly different scenario, but you're not plinkoing down just to the diagnosis. You're able to come back. So I think challenging people to apply is really important. And then I think sometimes you can do the reverse too, which is give the general foundational principle by querying with an open-ended question before you deliver the bite size. Yeah, another question. Yeah. Tips on building a dialogue for people who are tired. Residents. I think the biggest thing is really being able to say, what are your goals? And there's a member of the audience who changed my approach to education with her comment last year. You can't talk about goals and elicit goals without clarifying expectations. So one of the things that I do now, which is, I think it's very important to have a conversation about goals. Jesse, what do you want to work on? What are you working on as a senior this week? What have you been doing so far? How have you been approaching patients overall or running the team? That's great. But I think it's important for us as educators to talk about expectations. So I talk about two. Here's the bare minimum expectation for you. As a senior, I expect you to know generally what is going on with every single patient. That's bare minimum. What is the exemplar? The other side, exemplary. So I would put at a level above you. So instead of a senior resident, I would say, what would I expect a fellow, a hospitalist fellow? What would I expect a GI fellow? What would I expect a new attending to be able to do? Not only know about every single patient on the list, but anticipate problems for every single patient on the list, to be able to have a plan A for every single patient on the list. And what happens if your plan A fails? Where are you going to go? That's exemplary. And then that is a nice basis for conversation of goals, because then a learner can say, my goal is somewhere in the middle. I'm not bare minimum. I'm definitely not exemplary yet, but I want to get there. So I think that dialogue is very, very simple, and it doesn't have to be prolonged. It can be very quick. Like, hey, I really like when people do this. The best senior residents, the best fellows do this. Bare minimum. I mean, I think most people can say that it's easy to do this. This is what I think. Let's find something in the middle to work on. It can be a 2 to 3 minute long conversation. It can really enforce a lot of meaningful dialogue in feedback, in education overall.
We have one question in the chat, and the question is, do you do teletherapy versus via social media?
Teletherapy? I do not.
I think, yeah.
Maybe I should. Yeah. There's a question in the room as well. How do you assess self-confidence in learners of varying levels? When you're teaching as an educator? Yeah. I have a tongue-in-cheek kind of question that I ask most people. Not everyone, but I ask most people, which is, are you okay being good enough? Are you okay being enough to passable? Most people are like, no. Most people are like, no. And then I say, well, what do you want to be? I want to be great. I want to be excellent. I want to be the best. Okay. Well, the best have to do certain things. Really great physicians have to do this. Really great educators have to do this. Really good clinical, like critical thinkers, really good communicators do this. Are you prepared? Are you willing to put in the work? Because that's what it takes to get there. Now, it's domain specific. I do not have to be good at suturing. I am perfectly fine if I'm not going into surgery to be just good enough at suturing, passable, perfectly fine. But the domains that are relevant to where I want to go, do you want to be acceptable? Do you want to be excellent? And I think one of the best ways to motivate is tailor it back to patient care. At the end of the day, do you want to take care of patients really well? To be able to do so, here's some of the things that are important. Any final questions?
I don't see any further questions in the chat. Thank you very much, Dr. Tran. This is a great presentation and really appreciate it. Thank you.
Thanks for having me.